Hello and welcome back. So today we'll be talking about our first lecture on the approach to musculoskeletal pain. So the first talk will be a derivation of a logical framework for understanding the patterns of inflammatory arthritis. Now, as we move on to the topic at hand, or actually deriving the diagnostic framework for arthritis, you'll realize that it is actually a little bit different from the other diagnostic frameworks that I've been discussing as of now, and actually it is quite different from the diagnostic frameworks that are there in other problems that we encounter while practicing internal medicine. So in that, epidemiology and base rates of diseases play a very big role in the probability of a disease. Okay, many of the arthritis have very specific patterns of presentation, and that pattern of joint involvement is governed by certain basic principles, which in the correct clinical context can be very telltale regarding the kind of pathophysiology that is underlying the disease per se. Okay, so before we go into the diagnostic framework per se or proper, I will be discussing these in great detail, and then we'll go into the diagnostic framework in the next talk in this series. So see, the immune system is works in a very predetermined, very complicated but rather important predetermined way. The exposure of damage-associated molecular patterns or pathogen-associated molecular patterns to the innate immune system results in its activation. Okay, that is always the first step. That then subsequently leads to activation of the adaptive immune system. And as I'm sure most of you already know, the innate immune system is non-specific. It gets activated by specific molecular patterns, that is the damage-associated or pathogen-associated molecular patterns, but its specificity or the response it produces is only essentially can be put into two buckets, that is an antiviral response and everything else. So in this particular instance, I'm talking about everything else, not the antiviral response. So the adaptive immune system response, however, is highly specific. It is targeted against a specific molecular pattern on the target pathogen. Okay, now broadly speaking, the adaptive immune response consists of an initial response that gives a feedback, positive feedback to the innate immune activation and tries to resolve the pathogen exposure through innate immune means. Okay, because adaptive immune responses take, specific adaptive immune responses take time to develop. However, if there is a failure of the initial innate immune response, which is typified by the presence of a Th17 polarized T cell response uh, to clear off the pathogen, okay, that results in progression to the Th1, polarized T cell response. So, along with this, there is also a T follicular helper cell, that is T helper FH. This is FH. Okay, FH response, which activates B cells and ends up producing antibodies. So the antibodies are highly specific for specific antigens of the pathogen, and again the T cell responses, the T helper cell responses, are highly specific to the particular epitope or the particular molecular signatures on that particular pathogen that is infecting the host at that particular point of time. So once the proper Th1 responses develop, or the proper T follicular helper cell plus B cell responses develop, they tend to inhibit the barbaric initial non-specific innate immune activation. So this is in very broad terms how the immune system functions. Okay, now we can have certain perturbations of this that result in systemic autoimmune rheumatic disease, and that is something that essentially is the entire topic of clinical immunology and rheumatology. So let's see what can happen. So the first thing that can happen is there could be a failure of this progression from Th17 to Th1 responses. Okay, so this failure would result in prolonged excessive Th17 polarization, and that in turn causes prolonged innate immune activation, because Th17 responses activate the innate immune system responses. So that results in a type of prolonged innate immune activation, what is then considered an autoinflammatory disorder. Okay. Alternatively, what might happen is that the innate immune system itself is intrinsically more, more sensitive to the stimuli and produces out of proportion responses. So that is another category of autoinflammatory disorders. Now, the second thing that might happen is that the Th17 to Th1 responses are fine, okay, but the particular host, the human being infected by the pathogen or having the particular disease, has got a specific genetic HLA association that leads to an increased tendency to develop specific epitope responses. Okay, the best example of this would be obviously the shared epitope that results in development of autoimmune responses against cetylated peptides in rheumatoid arthritis. Similarly, the HLA associations of Hashimoto's thyroiditis, HLA-DR3, HLA-DR4, or say Graves' disease or myasthenia gravis. Okay, they produce very specific immune responses against very specific epitopes of a putative pathogen that doesn't really exist. So these are the true autoimmune disorders. Here what is happening is there is increased adaptive immune activation due to an actual antigen targeted immune response. This is against a specific antigen, and the person has an increased predisposition to developing florid responses against that particular antigen. Okay. Now, the third possibility is that, and this is very interesting actually, so the antibody that is being produced, that itself starts to, instead of inhibiting innate immune activation, results in activation of the innate immune system. So how this happens is that the antibodies actually bind to proteins that are bound in turn to nucleic acid. So these are nucleic acid binding proteins, and antibodies develop against them. Now, when that happens, the antibodies, as they are removed from circulation by phagocytic cells, they accumulate within the phagocytic vesicles of these cells, and these are the same vesicles that also contain the TLRs, or the innate immune receptors for those same nucleic acids. So as a result, the development of the antibody causes nucleic acid bound protein accumulation in the very cells that have the receptors for those nucleic acids. As a result, there is instead of a negative feedback inhibition of innate immune activation by most immune complexes, these immune complexes actually result in specifically increase in the activation of the innate immune system. So that is why there is a positive feedback, as you can see. Okay, so this specifically happens in one very specific situation, that is in all of the alpha interferonopathies, the polygenic alpha interferonopathies, specifically SLE, dermatomyositis, Sjogren's syndrome, systemic sclerosis, so ANCA vasculitis. So this is the third problem. Now the thing is that essentially all systemic autoimmune rheumatic diseases fall in these three spectrums of diseases, probably with the exception of sarcoidosis, where it probably could be fit into the second category, but the response is not against a specific single antigen. That is the thing. Okay. Now, moving on. So now, if there are these three separate mechanisms at play in different autoimmune disorders, so even though many autoimmune disorders affect the joints, how they affect the joints would be the pattern would be a little different. I'll elucidate that a little bit better. So as I said, the innate immune activation because of a failure of either because of a failure of Th17 to Th1 polarization, or due to basically an excessive innate immune activation, could be due to the failure of Th17 to Th1 polarization happens in our spondyloarthritis. So that is this group of disorders: the axial spondyloarthritis, peripheral spondyloarthritis, namely reactive arthritis, enteropathic arthritis, and psoriatic arthritis. Whereas autoinflammatory disorders are typified by disorders like Behçet's disease and relapsing polychondritis, as well as dyslipidemia related arthritis and intermittent hydroarthrosis. Now, on the other hand, the specific adaptive immune responses against specific antigens are developed in rheumatoid arthritis, which could be seropositive or it could be seronegative. Probably some portion of the seronegative rheumatoid arthritis patients actually fall more towards the peripheral SPA spectrum. Okay, but because of the hard boundaries that are classification criteria have to have, okay, by design. Often we have to draw a line here and we don't exactly know where to draw the line. Do I draw it here? Do I draw it here? So that is a question that is always up for debate. Now, psoriatic arthritis, particularly polyarticular psoriatic arthritis, would actually be under this category, in the second category. Okay, so I hope that much is clear. Now, the third is obviously all of the polygenic alpha interferonopathies. That would be SLE with or without antiphospholipid antibody syndrome. That would be primary Sjogren syndrome, dermatomyositis, a variant called antisynthetase syndrome, then systemic sclerosis and ANCA vasculitis. Okay, so these disorders therefore clearly fall on a spectrum, but there are some are closer to each other than the others are. And those of you who routinely do see patients with inflammatory arthritis would recognize that these two disorders are it's a routine clinical query that arises, that how do you differentiate them from each other. Similarly, if anyone has ever evaluated a patient with Behçet's disease or relapsing polychondritis, often it is difficult to differentiate it from peripheral arthritis. Okay, so we'll see how that why that is and how that develops. Infections also follow this rule. Chlamydia infections, gonorrhea infections, septic arthritis also tends to follow this same pattern. So those infections tend to result in innate immune activation. Chlamydia specifically because it prevents Th17 to Th1 polarization. We'll get to that when we talk about spondyloarthritis and reactive arthritis. Some infections, particularly viral infections, result in excessive antiviral, that is type 1 interferon production directly. So that would be your infections that take it too far. That is FAR is in this case PHAR. So that is parvovirus B19, H for hepatitis viruses and HIV, A for alpha viridae, that is alpha viruses like chikungunya, and R for rubella. Okay, now coming to the individual topics. So arthritis secondary to excess innate immune activation would be the result of two separate but at times overlapping immune phenomena. Okay, so one of them, as I've just discussed, is that the innate immune system itself is excessively active. Okay, the same stimulus that in a normal person would not result in a very florid innate immune activation. In this particular patient or this person, their innate immune system is excessively sensitive to these stimuli and responds in excess. So the prototypes of these disorders are Behçet's disease and relapsing polychondritis. What I would like to highlight here is actually in very specific scenarios, having this kind of an excessive innate immune activation is actually beneficial to the organisms or the host survival. So that would be, say, if the population is affected by a plague, that is Yersinia pestis. Okay, so Yersinia pestis needs to be stopped right in its track, right in the beginning of the infection. So those people who have innate immune systems that are that produce very florid responses would selectively have a higher chance of surviving Yersinia pestis infections. And therefore, if there was, say, a pandemic, as has been happening multiple times through the Middle Ages, subsequent in generations of people would have populations that are enriched in innate immune systems that are excessively active. This is likely the reason why populations around the Mediterranean Sea and along the old Silk Route or land Silk Route tend to have increased prevalence of genetic polymorphisms that result in Behçet's disease. Okay. Now the second thing is failure of, like I said, Th17 to Th1 polarization, which is essentially the characteristic pathogenic feature of spondyloarthritis, and this results in actually a loss of the or an inverse of the normal interferon signature that we get in, say, an alpha interferonopathy. Okay, and that is then called a negative interferon signature. Okay, so these two disorders are there. Now, so how would this manifest in joint involvement? So this person has got an innate immune system that is inherently excessively reactive. So we just need to follow where will the innate immune system be activated. So in terms of the joints are obviously protected from the external environment. Okay, they're not exposed to external or skin microflora or even gastrointestinal flora, anything like that, but they are exposed to mechanical damage. Okay, and they're exposed to mechanical damage because of what? Because of the vector of gravity. So this is your normal skeleton. Okay, I made obviously a schematic here, but I've overrepresented the joints. And you see this is the vector of gravity. So what would be the joints that would be affected or would be preferentially damaged or receiving excessive damage due to mechanical strain? That would obviously be the joints that are around the spine. Obviously, the weight of the patient is actually being transmitted through the spine via the hip joints, through the knee, the ankle, like this. Okay, and lo and behold, what do you find? That the distribution of the arthritis is also the same. So the arthritis usually affects the lower limb more, is usually affects the large joints more, is often asymmetric. Now the reason for why it is asymmetric is likely to do with the fact that any normal person does not always equally bear the weight of their body equally on both limbs. Okay, there is a little asymmetry in anyone, and once you start developing joint pain on the other side, automatically the other side of the skeleton is used more. So that results almost in an alternating phenotype or alternating pain, development of pain on alternate sides of the body. And the most characteristic clinical scenario in which you find this is patients who have lower back pain, particularly inflammatory lower back pain, that is, they tend to complain of alternating buttock pain, and this is actually even part of the classification criteria for inflammatory back pain. The asymmetric large joint, lower limb predominant or axial predominant arthritis, what you need to think is that actually this person's mechanical damage, the normal mechanical damage that in any person accrues through routine daily activities, is not getting controlled normally. Okay, and that is their immune systems, the innate immune systems, are excessively reactive, and because they are excessively reactive, they're producing prolonged inflammation at sites that are subject to this kind of recurrent mechanical micro trauma. Okay, so therefore the pattern is very, very telling and very reproducible. Okay, and can then be used by us for diagnostic purposes. Okay, the second thing is in arthritis due to excess adaptive immune activation. Now that is, there is a normal Th17 to Th1 polarization. It's just that the Th1 polarized cells, or even before that the Th17 polarized cells and the T follicular helper cells and B cells, all develop immune responses against one very specific antigen. Okay, so this is typified by the presence of two specific disorders. That is, one is rheumatoid arthritis and the other one is psoriatic arthritis. Predictably, both of these disorders would have very highly specific and reproducible class 2 HLA associations that everybody knows that for rheumatoid arthritis it is HLA-DRB1 haplotypes, and for psoriatic arthritis it is the HLA or class 1 HLA, that is HLA CW0602 haplotype. Okay, now so it's pretty self-explanatory. Here it is actually an autoimmune disease, and you would have noticed among the systemic autoimmune rheumatic disorders that only true autoimmune disorder is rheumatoid arthritis. Okay, I would say the alpha interferonopathies are also autoimmune disorders, but they have a significant feedback innate immune activation. So does rheumatoid arthritis have an innate immune activation, but it is not per se due to the antibody, and we'll get into that when we go to the individual illness scripts of these disorders and go into detailed immunopathogenesis. Because Th17 polarization itself causes innate immune activation, here also you get a lot of innate immune activation, but again it is secondary to the joint disease activity. There is a lot of nuance to that, and we'll be discussing it. So I would suggest that we'll leave it till that. Okay, so what would be the expected pattern? So the expected pattern should follow the distribution of the antigen against which the adaptive immune responses occur. And see, each human being is extremely different from the other, so this could vary from one person to another very significantly. But I can say one thing for sure, that it is not going to follow the pattern that we discussed for innate immune resulting from excess innate immune activation. So it usually is symmetric because there is no reason for asymmetry. Okay, it usually is small joint predominant, and it is usually upper limb predominant, but it can be a lot of other things also. Okay, but definitely a lack of symmetry would be something that we would find very odd. Okay, or at least persistent lack of symmetry. So initially, okay, by chance the initial responses occurred in one joint, but eventually there should be some symmetry. Okay, that symmetry should develop. Persistent symmetry would be very odd. Okay. Similarly, small joint predominance is expected. Even lower limb involvement could happen initially, but we would expect that eventually the upper limb joints are also affected. Okay, they shouldn't be spared because there is, the disease is not because of innate immune activation, and because they don't undergo that much mechanical micro trauma during daily use, they don't get affected. Okay, so these three parts of the pattern of arthritis would be expected to develop at some point, maybe not at the initial presentation of the disease, but at some point. Importantly, axial involvement would also then therefore be or less likely. Now I want you to contrast this to the pattern that we saw with arthritis secondary to excess innate immune activation. So here you got large joint involvement, and we got asymmetric involvement, that is lower limb predominant, and there is axial involvement. Okay, there is axial involvement, whereas as I've just discussed, there is symmetric small joint upper limb predominant involvement without axial symptoms in cases of excess adaptive immune activation. Okay. So obviously, since both of these fall under the same bucket, it would then make it very difficult to differentiate polyarticular psoriatic arthritis from rheumatoid arthritis. This is to be expected. There are certain ways of doing that, and we'll get to it when we talk about the individual disorders. So let's put a pin in that for now. The last type of disorder that you might have is an arthritis secondary to excess adaptive immune activation, which in turn activates the antiviral innate immune responses. And how this happens is, basically you've got a specific antibody developing against a protein that binds nucleic acids. Okay, now what happens is, your phagocytic cell, say a plasmacyte or dendritic cell, phagocytoses this entire complex. Okay, now once it has phagocytosed this complex, this antibody bound to this antibody bound to this antigen and the nucleic acid that was bound to it are now all three inside the phagocyte or phagocytic vesicle of the plasmacyte or dendritic cell. Okay, or any other antigen presenting cell. And as we know, some innate immune pathogen associated molecular pattern receptors, say specifically here it is TLR3, 7 and 9, are getting exposed to this nucleic acid at an increased rate. So the plasmacyte dendritic cell thinks that there is a viral infection, and it ends up eventually producing type 1 interferon. Okay, now this type 1 interferon in turn activates more B cells, and those B cells, because of the patient's genetic association or prediction for production of these anti-immune nucleic acid binding protein antibodies, okay, results in more production of these same antibodies. Okay, and that is the positive feedback loop that perpetuates these such disorders. Depending on what cell is producing this type 1 interferon signature, these disorders can be divided into further categories. So again, what are they? So this is the positive feedback that develops, okay, because the antibody itself is inducing excessive innate immune activation. Now it would be SLE, that is systemic lupus erythematosus, it would be dermatomyositis, and it would be primary jaw ulcer. Here the SLE is the archetype, but actually the differences between these disorders are to do with the fact that in SLE it is the plasmacytoid dendritic cell that is producing the type 1 interferon signature. In dermatomyositis, it is actually the intramuscular myoblasts that are producing the type 1 interferon signature. And in Sjogren's syndrome, it is actually the epithelial cells of the glands that are actually producing the type 1 interferon signature. So two polygenic alpha interferonopathies are variations on this general theme with resulted changes in the pattern of arthritis. So both processes additionally involve the joint hematogenously, and these essentially are systemic sclerosis and ANCA vasculitis. So in case of systemic sclerosis, what ends up happening is a vasculopathy, and in case of ANCA vasculitis, we have actually a small vessel vasculitis. So since both of these are vascular processes, larger joints with more capillaries are more likely to get affected. So there is a predilection for larger joints, okay, particularly an awkward set of joints. So that is the ankle, wrist and knee. Okay, and often the involvement is asymmetric, although it can be symmetric. So this can be quite telling actually. This is a slight variation to the general pattern of polygenic alpha interferonopathies. Now, so the involvement may be, non-gravity dependent. So gravity dependent joint involvement occurs when a disorder in which the primary endocrine damage is because of antigen antibody complex deposition, something like SLE. The deposition of those, or cryoglobulinemia vasculitis, the deposition of the antigen antibody complexes would follow the gradient for filtration of those antibodies into the target tissue, and that obviously depends on the hydrostatic pressure within the capillaries, and that in turn depends on the where the particular capillary bed is located vis-a-vis the craniocaudal extent of the patient's body. So the more towards the feet, the higher the pressure gradient, and therefore more likely the capillary, the antigen antibody complexes are to get deposited in those capillaries. So such a distribution is then called a gravity dependent distribution. So this kind of distribution is reflected in the arthritis that develops, the skin involvement that develops, and the peripheral nerve involvement that develops, and that is why cryoglobulinemia vasculitis tends to have all three in affecting the lower limb, symmetrically. Now, on the other hand, ANCA vasculitis would not show this kind of a gravity dependence. So it can show significant involvement of joints that are not present in the lower limb, so the elbows and the wrists. Okay, and also they often show an asymmetry, a significant asymmetry. So like I said, the mnemonic I use is awkward, so that is the ankle, wrist, and knee. One more thing that is very important is that the number of joints that are affected could vary very significantly from patient to patient. Now, in case of systemic sclerosis, because there is also fibrosis that happens, the joints secondarily get fibrosed, and that is called a dry synovitis. Okay, so no significant effusion occurs, but eventually there is a restriction in the range of motion of the joint. With ANCA vasculitis, often the arthritis is acute or transient and resolves spontaneously or completely. Okay, so that brings us to the end of this discussion on the logic behind the four patterns of joint involvement in inflammatory or autoimmune and inflammatory rheumatic diseases. So in the next talk, we'll be discussing how we apply this in the context of the prevalence of each of these disorders, because the different types of arthritis differ from each other in terms of prevalence by a magnitude of often 10 to 100 fold. So we cannot ignore the base rate of any of the diseases. So we first take into account the base rate, and that depends on how long has the arthritis lasted. It depends on whether there are inflammatory features or there aren't any inflammatory features. So we'll get into that in the next talk. Till then, thank you for watching, and I'll see you next time.